before we get started, we know that the local welcome everybody. I'm Sherry Pereira. I'm the Chief Grad Advisor here at OSU. And this is the 4th year that we've done this program, and it's been really fun and successful, and I was learning a lot. I look forward to it. The students had a good time doing it. So we're just lucky to have some really great people that are here to help us do this. But I do want to make one quick announcement, and that is that how many of you have been over to the Comp Northwest campus at all? On November 11th, they're actually doing medical school interview panel discussions, so that'll be another opportunity for you to do that. And you just have to get on the Comp Northwest, the OPSO mailing list, because they do want RSVPs for that. So just wanted to make that announcement since the theme of tonight is interviews. Come on in. And try to sit down a little bit down here if you can. It's great. Okay. So, I'm Sherry Pereira, as I said. This is Dr. Gabe Ledger, who is an emergency room physician, and this whole team has been here every year, which has been a really fun thing. Many of you know Dr. Kevin Ahern, who's one of our interview gurus here on campus, and many of you know this guy who's busy doing his homework right now, practicing last minute, Dr. Courtney Campbell, who has an assistant, Kelsey Brewery, who is the first time for that. And so we are going to record this, so I want to make sure that you know that. We're going to be in the visual part, but you will be on the audio part if you respond. So if you're not okay, then just come up and whisper something afterwards, I guess, because you will be on tape. And be sure to speak up. And Kevin, you want to say something?
Yeah, please do speak up. So the quality of the tape, there's only one microphone in the room, and so the tendency of people is to not speak very loudly in general. And this video, we really want to have available for a lot of people to use and understand. And so when they can hear things that you're saying and that we're saying, we're going to work on speaking loudly also, then it makes it for a better video. So that's why I say the closer you can sit to that, the less you have to worry about that. So if you tend to be a naturally soft speaker, sitting close to the camera might be good. Okay? And as Sherry said, if you have any problems with being on camera or having your words heard on camera or something, let us know and we'll see, we'll work something about that, okay? Okay. So thanks, everybody.
So then the way it's going to work is that Courtney Campbell has some scenarios. We'll pick somebody who is going to be a wonderful volunteer, and priority goes to people who are in the application process. I know a lot of you are in that category. And then we'll just talk about it. We'll try to do an 8-minute, occasionally we'll time them for 8 minutes, which is really what the MMI format is. But then we'll just chat about it and go back and forth, and everyone's welcome to make comments. And that's where we really learn a lot. So.
Okay, just hoping there'd be a chair or something. I guess there's one.
This one.
Chair.
Yeah, there's a couple chairs.
Okay.
Okay.
So some of you know I do a lot of case studies in my medical ethics courses and medical humanities courses, and as part of that I like to do role play. So what Ms. Drury and myself are going to be doing is just very short role plays of some cases that are actual cases that appeared in medical literature, New York Times, one place or another, and then we're going to invite one of you, or at least some of you, to join us in the role play. Okay, just think what would be the next thing you would say as a physician in this particular situation. Okay, so I'll just say how it goes. This is entirely unscripted, so don't worry about making mistakes. We're going off our own write-ups here, but welcome into the.
Good afternoon. What I have here on your chart says that you are having some issues with headaches.
Yeah, I've had these real deep headaches for the last couple months or so. I mean, they've really been interfering with my work, they've been interfering with my concentration. A lot of pain. I've tried some medication, but pharmaceutical companies have good medications for headaches. So I need some help with this.
All right, and there's been no trauma to your head that you're aware of that could have caused these?
I don't think so. You know, I've actually got something that, is there something I can tell you in confidence? I mean, if I tell you something important that I think maybe is part of this, you'll keep it within the room here.
Whatever I hear stays in the room.
You know, a little bit over a year ago, it's really hard for me to say this, but a little bit over a year ago, I was involved in a serious crime, committed a serious crime. And in the course of the proceedings, someone else was accused for the crime. They took the fall for it, and they're now in jail for it. And I feel badly about that. It's been causing a lot of stress. But anyway, I just felt you should know about that. And, actually, now that I just said it, I feel so much lighter in my head. Yeah.
Well, I appreciate the information. It's always good to have the full story for something. I think we're going to have to look into this a little bit.
Well, I really appreciate you assuring me of giving me your promise and your word that you'll keep this within the bounds of this room. Thanks.
Good afternoon. So this is our hospital lawyer. I have recently had an encounter with a patient in which he informed me that he was involved in a crime in which someone else may have been wrongly accused and is now being prosecuted for that crime. I gave him a promise of confidentiality, and I need to know if there are any legal ramifications for me maintaining that confidentiality.
There's no legal obligation on the part of the physician or the hospital to report the incident because the patient did not pose a risk of harming himself or others.
Very good. All right. Well, thank you. That's something I'm going to have to think about.
Now you're going to anguish.
Okay.
Well, on the one hand, I did give Mr. Campbell my promise that I would keep his secret. However, I would say I'm very conflicted as to whether or not I can, with my own morals, maintain his confidentiality, as I'm concerned about perhaps feeling like an accomplice in this crime, where someone else has now been put in jail or punished in some way for a crime that they didn't commit, according to what the patient has said. I don't know whether or not I should pursue this further, whether that falls within my realm of responsibility, and what I should do regarding this balance of confidentiality and the guilt I feel now that I have gotten involved in this process.
So you're to act as Dr. Drury's conscience here. She's conflicted. What are you going to tell her?
So I'll time it for 8 minutes.
Okay.
Okay?
All right.
Who would like to start?
Who wants to go?
Nobody
Good.
wants that.
That's what a conscience will do, is think it through.
Well, so there's no legal obligation, but is there a problem if she does tell anybody about the confidentiality? Like, would she get in trouble because she did not keep the confidentiality? If she were to tell someone about what the patient said?
Why don't you ask the hospital attorney about that?
Just repeat the sentence.
It says there's no legal obligation on the part of the physician or hospital to report the incident because the patient does not pose a risk of harming himself or others at this juncture.
Can I make a recommendation here? So one of the things I tell students in thinking about MMI format is the tendency is to do exactly what you just did, which is to ask more questions. And committees frequently may just simply say, well, what do you think? Which leaves students very unsettled by that. And so my recommendation to students is to ask yourself the question. Is there an obligation, legal or otherwise, for me to need to do this? And then what you can do is you can answer the question both ways. Well, I don't know offhand whether or not this is a legal consideration, but if it is a legal consideration, I really have to be consulting with the attorney, et cetera, to make that happen. If it's not a legal consideration, this becomes a moral question. Understand? So now by analyzing that question yourself, you're actually contributing the answer to the MMI part of the interview. Does that make sense?
Yes.
Okay.
Dr. Brewer is still consulting our conscience here.
I think as a physician in this case, you have to kind of look at a couple of different avenues, because as a physician you're expected to uphold the Hippocratic Oath and kind of maintain patient confidentiality, but at the same time you want to be kind of a healer within the community and be a positive member of society and make sure that you're maintaining integrity. So I believe that you have to make the decision of which avenue to take and which kind of code you'd like to uphold more. And in this situation in particular, my choice would be to report the crime in order to be more of the positive community member rather than the person that maintains confidentiality, because I see reporting this person as contributing to the greater good of the community rather than maintaining that patient confidentiality and not upholding your role in a more, greater sense of society.
Great, could you come down just for a minute? I'm not going to attack you. Yeah. No, not you. Oh. The gentleman that just she's going to ask you, and I want you to say what you said to her rather than to us. Just dialogue with her.
Okay. Do you want me to sit down?
Say it loud, yeah.
Okay.
She's consulting with you about a patient she's had.
So I recently had a patient come in. He has informed me in confidence that he was involved in a serious crime for which another individual, presumed innocent, has been convicted and is now receiving the punishment for that. He did tell me this in confidence, however, knowing that someone else has been affected by this, I'm very conflicted over what course of action I should take. Whether I retain his confidence or whether I am called upon to take this and report the crime.
Okay. As a physician, it's important to uphold the Hippocratic Oath and maintain patient confidentiality, but at the same time, it's also important to remember your role within the community as a healer and a positive influence within society. And taking into consideration both of those potential avenues, I think it's important to uphold the greater good of society and report this person, because there's a chain of events related to this person's crime that affect not only the person that was not convicted of the crime or that was convicted of the crime, but also the patient that you're seeing that's having these headaches due to this conflict. And by reporting this person, you'll relieve their headaches because the truth should come out. And also you should be able to help free the person that's been wrongfully accused of this crime. And as a physician, being able to not only relieve the symptoms of your patient, while it is breaking the Hippocratic Oath to an extent, you're relieving the symptoms of your patient, but also helping to promote a more beneficial and just justice system, which is greater than simply maintaining that patient's confidentiality.
So with this course of action, I'm not only relieving the headache, I'm also righting the societal wrong.
Right.
Great, thank you very much. Someone else? I'm feeling a little bit hung out to dry here, so I need we need another consult. Someone else want to provide?
Give the other shoulder.
And can we, is there another tack to take here? We've kind of focused on the legal thing, but we didn't actually finish up with the actual patient. So I'd like to see somebody, what are you going to say to that guy? Mr. Crime. So who can start asking, who can think of ways to address how you might get to him to do the right thing? Who wants to take that on?
I'll do it.
Okay.
Yeah. Sure. So how long has this headache's been bothering you exactly?
Just about a year.
Just about a year?
Yeah.
And so do you have any idea what brought these on?
Just been under a lot of stress in my life. You know, difficulties at work, difficulties in my relationships at home. Yeah.
Okay. Have you tried anything to alleviate the discomfort you're currently experiencing?
I've tried usual medications, aspirins, and so forth, but pharmaceutical companies are just in it for themselves, and so I haven't really found anything effective. But now, can I tell you something?
Oh, sure. Absolutely.
I mean, I understand the part of the Hippocratic Oath that you all take as physicians is to maintain my confidential information, right? So,
yes, sir.
Can I have your promise that what I tell you will be kept in confidence?
Yeah, my promise as a professional that I'll keep everything in confidence.
As a professional, okay.
Go ahead.
Well, a little over a year ago, when my headache started a year ago, I was involved in the perpetration of a fairly serious crime, and another individual was prosecuted for this, convicted, and now they're incarcerated. They took the fall for me. That, I think, is sort of the background to a lot of my headaches, a lot of my stress, my lack of concentration in work, and my difficulties in my relationships. So I just wanted to get that off my chest and out of my head. And I'm just so appreciative that there are people like you in the world that I can say these things to and know that they will not go outside of this office.
Well, thank you for communicating with me. Part of the foundation of a good patient-provider relationship is open communication. So I'm glad we've established that kind of a foundation. Would you mind sharing what kind of happened with that ordeal? If anything you'd like to discuss as far as specifics or the nature of what happened, or might make you feel better?
Well, my friend and I, we were just out kind of for laughs, and we're a little bit stoned a little bit, and we jumped a guy, and pistol whipped him, and took him out pretty good, and beat him up and robbed him, and the police saw my friend. Didn't see me. He didn't turn me in or rat on me in the proceedings. So I'm out safe, I'm richer, and I got some headaches. So, but now I don't. I think I'm really feeling pretty good now that you've given me your assurance that this information will stay between us.
Okay. I have a question.
Go on there.
Oh, whatever you want to do.
Yeah, let's play that out a bit more.
Sure. I'm glad that we're making some progress today. Is there anything that you think could help you further prevent the recurrence of these headaches? I mean, do you think that this conversation, this one time, is going to resolve the issue in the days, months, and years in the future?
Well, it's hard for me to know. It's the only time it's happened in my life where I kind of lost control. But maybe at some point in the, as we continue our relationship, we can talk further about it.
Okay. Part of the foundation of being a physician in this society is that we don't make medical decisions for people that are of sound mind and body to make decisions on their own. And so, I'm here to collaborate and help facilitate and empower you to make excellent decisions, but the decisions still come down to you as an individual. Is there a possibility that you could be experiencing some guilt or some regret given the events that transposed previously?
Yeah, I'm sure that's part of the underlying symptoms that I'm experiencing.
you think there's anything you can do about that as an individual? Maybe with some support?
Speaking with you has been just great. I mean, just being able to get it out is really good.
Sure. Well, you know, I can only give a testament from my own experience that, you know, we're all human, we all make mistakes. And unfortunately, if we don't resolve issues in our personal lives as well as our professional ones, they tend to spiral out of control. You know, that's how a lot of relationships are ruined, that's how a lot of different problems in other aspects of life continue as well. And so from personal experience, I think that you should resolve this issue as soon as possible before it causes more problems. You know, what happens if you can't resolve the headaches and you start becoming addicted to narcotic pain medications, which we all know the road that leads to, as many individuals have experienced, both from the provider as well as the patient perspectives as well. And so,
Switch.
Yeah. Good perspective.
I like how you sort of brought up and laid out the issue for the patient, but at the beginning you weren't really prescriptive about telling the patient, well, you should feel guilty about this, or you sort of said, well, how do you feel about that? Is this something you're feeling? And you kind of gave them space to say where he was, which was nice.
Did you notice any other things from either the two interactions there of the individual that spoke either to Ms. Julie or myself? Since when I was there in the last one, I don't know about Kelsey, but you looked me straight in the eye. I mean, you were present with me. The body language was very, very focused, but also relaxed at the same time. That was very good. And then you said, in your personal experience, which gave me a sense that you probably weren't quite there with me empathetically, but you were getting there. Okay, you're trying to say, okay, I can relate a little bit to what's going on. So you're expressing empathy. That brings me as a patient into more receptivity to you.
The other thing I liked about it is there's firmness. Okay, so one of the things I work on students thinking about is how strong you appear. A professional has to be firm, has to be somebody who is not pushed around. And so you came across very much to the point, and you were not going to be swayed based on the things that you were saying. So I thought it was a very good performance in that respect.
Ready for another one?
Yeah.
Okay. All right. Doctor this time. Well, Ms. Drury, it's good to see you again. You know, we've been seeing you a lot, or at least every year. You've come in for your annual examination. How are you feeling generally?
I'm well, you know, the job is good, it keeps me very busy, the kids are good and, you know, keep me even busier, so.
How's your health?
Health has been relatively fine. I feel fine, I haven't really had any issues, but, you know, I prefer to be proactive, and I know that they've found a few things on the mammograms in the past, and I just want to keep up with that.
Yeah, so that's why I wanted to just briefly talk with you. In the course of doing the mammogram this time, the radiologist noticed that there were some small calcifications on one portion of your left breast. They weren't really present prior to the prior examinations that you've had over the last couple of years. So the radiologist recommends that we proceed with a biopsy just to rule out any possibility of where are you going? Any possibility of breast cancer. So that's our recommendation, and I'm appreciative of how good you've been, you know, in terms of self-care over the last 3 years, and continue your annual examinations. But this is our recommendation at this time.
It just seems now like every time that I see you guys, you want something biopsied. It's been three times out of the last 5 years that you've asked to biopsy something that seems suspicious on the mammogram, and I've done it each time. And every time it's turned out to be benign. You know, all 3 times under the microscope, there's nothing there. You just don't know when enough's enough. And whatever these specs are, they keep turning up, but they have proven to be normal. I'm not getting another goddamn biopsy.
Wait. Okay, and what do I say now? What do I say now? I need someone to come and take this chair and bring my patient back. She's on her way out the
You
door.
guys have got interviews on the horizon. You better get up here. Come on.
I don't cry.
She does.
All right, Ryan.
All right, would you please come back in the room and I don't want you to leave upset, and I'd like you to have all the information that you possibly can have about this. So I understand that you're upset, and you feel like every time you come in here we take biopsies or do another procedure that I understand you feel you don't need. Is that correct?
It's not necessarily that it's, at this point I feel that it's not necessary. It's been the last three times in 5 years I've had the biopsy. It's proven to be normal, non-cancerous in each of the last 3 times, and I don't see any reason to waste my time doing the 4th.
Okay, so how does it make you feel when we tell you you need to have a biopsy?
Frustrated, like I'm wasting my time and my insurance money.
Okay, how does this affect, I understand there could be some time in between our recommendation and you getting the biopsy and results. Is that part of the problem?
No, the problem is that I have to come in for a day, have an open procedure, recover from that. I'm missing time at work, I'm missing time with my family, and it seems to be relatively unimportant to have it done, as each time it's turned out to be benign.
Okay, I understand how you could feel like that. And many patients do when you're going through procedures that you feel are unnecessary. But the reason we do it is because since we see something abnormal, there's a risk that you may have a disease, and potentially a very serious disease. So what we want to do is make sure that your health is assured, that you have the best health care you possibly can receive. And it is your choice to have a procedure or not. But from my perspective, since you have a potential disease, we would like to explore that further. So if it is a cancerous lesion, we can take steps to get rid of it before it spreads throughout your body.
What I don't understand is why it would be any different this time than it has been for the last 3.
Okay, good. Pause. Thank you very much. Okay, good job. Okay. We need someone else to sort of, again, start from the scratch, okay? Just work through, try to get your patient calm down, and listen to what you have to say. Someone else want to join us up here? Please. Yeah, talk to a patient. It's good practice. And she's not going to bite you, I promise. She's just really excellent at this.
Come on, people. Otherwise, we're going to call it.
We'll just call it a night. All right, great. Yes.
You guys have done this before.
Ms. Drury, can you please come back? I wanted to say that I understand your frustration, and I understand that the last 3 times have been a waste of your time and they've been a waste of money for you. And I understand that this can be very, very angering, but I want to explain our reasoning behind it. So each time we see something like this, we are worried that it could potentially be a cancerous tumor. And just because it showed not to be malignant before doesn't mean it can't be malignant now. So we're being as cautious as we can because we care about your health, and we really want to help you out as much as we can. So I understand your frustration, but I want to make sure you know a few things before you leave, because ultimately this is your decision. So I want to say that each time that we see something like this, we suggest that it gets checked out through biopsy, just to make sure, because if something like this is left unseen for a while, it can spread rapidly. So that's why we want to do this as quickly as possible. But it is your decision, so we respect your autonomy, and we want to let you know that you can come back in, and if possible, we could schedule a time with you. We can check up. We can check to see if anything has changed, or we can check, or even if you notice any changes yourself, please call as soon as possible, because we want to make sure this is checked out. And if we do see a change, then that means we definitely would like to get a biopsy, because that could mean that it's turning into a problem.
So the second appointment you're suggesting is another scan as opposed to the biopsy?
Yes, it would be a scan, because if either we schedule one now, in the future we could do it, say, like next month or whenever it's available for you, and do another scan to see if anything has changed, or if you notice any changes, anything different, then call us as soon as possible, because we want to be able to scan it again and potentially lead to a biopsy after that.
Another one?
Yes, because if it's changed, then that could mean if it's changed in a short time period, could mean it's a potential problem.
Right. Well, I appreciate the fact that you've been very understanding. At this point, I certainly don't want to proceed with a fourth biopsy. I don't have that kind of time to take away from my job and my family.
I understand.
I don't see necessarily a reason to proceed other than having my annual mammogram. I don't know that having another in a month or 6 months even will be very much a good use of our time.
Okay.
However, I will certainly continue with self-exams.
Okay.
It seems like, for me, that would be the most reasonable course of action at this point in time.
Okay. We respect your decision, and definitely continue your self-exams. If you have any questions at all, please call us. Please tell somebody, because we need to keep this checked on.
Is there anything in particular that I need to be worried about or looking for?
If you notice any changes where the lump is, or if you notice anything that is different than it is now, definitely call, definitely let us know, and we can get that professionally looked at just to confirm it, of course. Or if you notice anything in your health that is changing, it could be related to this or not, please let us know.
Okay, why don't we just jump? So observations about either content, because we did get two different approaches there, or style. Dave, maybe if you had anything that you wanted to...
Maybe I'll just hear what people say.
Okay. Allison?
I was just going to comment that I liked how you gave her a different approach that she could take, that was kind of an in-between option. I thought that was really, really good.
How come we never mentioned having another radiologist look at the mammogram just to double check, to reassure the patient that this, is actually something to be concerned about, and reassure that as a physician we do not want to order more scans that need to be done and cause more further harm, because radiation is a big deal, and maybe convince her that way.
I liked the way, Brian, that you pulled out what her concerns were right from the get-go. That's essential. That getting her to talk about it, and that calmed her down too.
I just had a question. So the main concern was that the patient didn't want to waste time, didn't want to take time away from her family. But would it be wrong to pose a question of, what's going to waste more time? You going and getting this one more exam, or the fact that you have cancer? How's that going to affect your family? Posing that question.
Jake, what do you think? I mean, I know what I think about that one. You're the one that actually does this, and I just read about it, so.
So that's a good question. I think if you take it a step back, I think the main issue to me here is sort of two buzzwords that it's probably good to know if you're doing interviews, because they're very talked about a lot in medicine right now. So one is patient-centered care, the other one is shared decision-making. And so I think this case kind of boils down to a conflict of priorities and values, right? So the physician has a set of priorities and values. We got to do the mammogram, we got to diagnose the potential cancer, You have to do active screening for potential disease. I mean, clearly the patient has a different set of values and priorities. And so I did like the person who first spoke to her did give her the space to put that out there. I forget exactly the question, but it was very open-ended. Said, what are your concerns here? And she did give some concerns. I think for me, you want to go a little bit further there. You want to have the patient tell a little bit more about their concerns, maybe more than their specific concerns about the time, but get at their values. So the time is a priority for her, but what are the values behind here that makes her make this decision right now? And then I think once you get more of what the patient's values and the patient's story is, then the approaches that you were taking, you were giving different options. So hey, there's a few different ways we can go here, depending on kind of what your values are, really. And then the idea about getting a different radiologist, that's another option. That's sort of another pathway. Well, we could also get this checked out. We could do a watch and wait type of approach. And I think at some point, and I think it's much later on, you can communicate your physician concerns. I'm afraid that we might be missing cancer. But if you do that at the beginning, I think you're losing the patient. Because that just sounds like a typical doctor just telling the patient what to do without listening to the patient's concerns.
I guess if I was, and I am no doctor, believe me, or at least I'm no medical doctor. If I were Kelsey, I don't know how Kelsey would respond to this, it'd be interesting to ask you, but if I was brought back in and the physician didn't ask me, kind of, what's up? Can you tell me a little bit more about what's going on with you right now? I see that you're really, really agitated, really, really distressed. Can you tell me more about this? I wouldn't start at that point. I wouldn't start, I can understand you're upset, and every patient, is going to be upset by news like this. I wouldn't start there. I'd let it be first person. Get her use, let her give her voice, and then after that, if this worked out, then you might be able to ask some of the more the kinds of questions about missing cancer that you might, or the priority issues. But I'd let her get her voice out, because right now she's going away, and you might not ever see her again. And that's not going to be good for you or for her. So, again, this is a case, true case. Atul Gawande writes about this case in his book Complications. So it's one that we dealt with.
So one of the things I think that I want students to keep in mind is that role-playing in MMIs does occur. And you may be interacting with actor or actress playing out a scenario. And the role of the actor or the actress in that MMI is basically to counter you. Okay? So remember that. So one of the things that students feel that they have to do when they do a role-playing like that is they have to convince the actor of something. And the actor's job is not to agree with you. Okay? It's not to agree with you, but it's to make you flesh out the whole scenario, the whole scene of what's there. So one of the things that you should always think about when you're doing a role-playing is, am I covering the subject broadly? Am I illustrating compassion? Am I doing all of the things that I would necessarily do with a patient? And don't worry about what the person says at the other end. If you feel that the person hasn't been convinced by the end of your thing that you failed, you're very wrong. So don't engage in argument. Argument is not going to get you anywhere. Okay? That's a very important thing to remember. Okay?
That's a great comment. And the other thing I was thinking about along those lines is I almost think a good comment might have been at some point in this discussion with the patient to actually apologize. The physician can say, you know what, I'm really sorry. I think before we ordered that mammogram, we never really had the discussion about your different options about even getting a mammogram or what your options as far as what the results might be. And maybe we should have talked a little bit more at that point about what your concerns or your values are. So that's sort of another thought I had. Again, yeah, not engaging the patient in argument, but really trying to get more of their voice to come out.
Yeah. Want to try another one?
Yeah.
Yeah.
I'm going to try the association one.
Yeah. So you just
Yeah, it's basically, we're going to be talking struggle, people who might question career. You're just going to be listening. You're going to be the sympathetic listener. Yeah, so I just go. Yeah, this is the lunchroom.
I had another patient come in today whose mother would not allow me to give her vaccinations as scheduled. And this has been an ongoing problem. In the past, I've documented the refusal and moved on. But now I'm thinking I want to change. I want to change my approach. There's just too many unvaccinated children that I'm seeing, and I'm looking at not having that herd immunity. I'm thinking I want to start insisting that my patients receive vaccinations according to the standard schedule, unless of course there's a specific health-related rationale for why an individual child should not be vaccinated. I believe that I want to begin not treating children in my practice unless they are vaccinated on schedule. I would like to get some thoughts on this new policy.
I think this is, would you guys jump in?
Yes.
So I'll start the timing.
Just me 8 minutes ranting or discussion.
She laid it in your hands.
Okay, great. Yeah, Kelsey, I see this all the time in my practice and work with my patients. Is there's some people that just don't have a tendency to want to get vaccinated, and it's frustrating. I mean, we both understand as doctors that it's critical that we have as many people vaccinated as possible. So what are the ways we can go about trying to improve that? I know you're frustrated. I know you want to see results, and it's just not happening, especially in this area. But I would encourage you to take a more proactive approach with the patients who are less inclined to receive vaccinations. Maybe not so taking such a hard line as refusing them, because that doesn't do them any good. It doesn't do the population any good, because they're not getting vaccinated either way. We're sort of put in a unique position where hopefully they trust us at least enough that we can build on that relationship and maybe convince them to move forward with vaccinations. At the end of the day, you're going to have those people who are just very hardline against it. And after we exhaust all of our options and really discuss with them, should maybe try to show them some research, or maybe talk to someone who they really trust. If we exhaust all our options, there's nothing to do there. But I think from what you described in your patients, there might be a few folks that we can still kind of bring over. And at least if you're not vaccinating them, we know who they are, and we can make sure to treat them best if they do come in with a disease that you may could have been preventable.
Yeah, you raise an interesting point, because as you're stating, if I just stop treating them entirely, that's really not doing anything beneficial for the community. And it almost seems like a bit of a selfish approach, perhaps.
Yeah, at least engage. You should engage them. Let's give it our shot. And if really nothing's happening, maybe refer them to another doctor. But we don't want to abandon them, because that's only going to make the problem worse. And then even if we put a little pushback, maybe that'll make them less inclined to convince people in the community that vaccines are inappropriate. So we want to be as proactive as possible.
Yeah.
Good. Thank you.
Thank you.
Can I do something super quick?
Yeah.
Okay.
Or do you want?
No,
Go ahead.
I just want to, can you guys switch seats for a second? So you're the doctor now, you're the patient, or you're the family member who's just said, I don't want to vaccinate my child.
Yeah, that's good.
What's the first thing you said? Or we're going here where you go?
It's pretty standard. We recommend vaccines for everybody. There are a lot of benefits for it, but I'm kind of curious about where you're coming from. Why you feel vaccines aren't appropriate for it?
Right. Well,
All right, can I start right there? Does anyone notice a difference? What's different between what he just said right now and what he said as when he was sitting in this chair?
He was more focused on her opinion and her approach than kind of just telling her information or giving her advice.
Yeah, exactly. This is a brilliant scenario, actually,
Yeah,
because
it's good,
because he was talking to a physician, he didn't talk to her as a patient, and he kind of talked to her maybe in more of a direct and maybe just more direct way. But then when she's a patient, he did take a very open approach and said, "Oh, what are your concerns?" But when he was talking to a physician, it didn't really elicit her concerns as the physician. He just said, "Oh, you're a friend of mine. I can just kind of tell you what to do. You're a professional." But there's no reason why you can't. Sorry, I just wanted to.
The same thing, so that was good.
Correct me.
Yeah.
Oh, there was no hand? Yeah. Yeah, you
want to say something?
Oh,
And I think it's very natural. You know, it's very natural. You see sort of your colleague, and I've done this every day. Colleague, oh, you did that? Oh, yeah, you should just do this, do this. And then we talk to the patient. Tell me more about it, and tell me your values and your concerns. But yeah, even when we talk to our colleagues, we need to be eliciting their concerns and find out, why does it bother you so much to not have your patient vaccinated? I mean, that's a valid question. Why does it bother you? Does it scare you? Is it just that you think they're making bad decisions? Is it?
And I love the get at their values. That just seems so incredibly important.
Is there another hand that is raised by someone?
Make comments about this one.
Yeah, I just had a comment. There was mention of the buzzwords of patient-centered care and shared decision-making, and when you change seats,
right.
When you change seats, it was definitely good to see that you're shifting from speaking as equals with the other physician to focusing on the patient and how they're feeling and being able to empathize. At least that's what I've gathered from those buzzwords of patient-centered care and shared decision making, making sure that the patient is the person who's making the decisions rather than you're just telling them you need to get your child vaccinated. That's the end of the story.
I think actually, if I were having this conversation today, and I were trying to convince a patient of this, I would say, that our perspective on vaccinations really changes depending upon the scenario in which we exist. Because I'm very anti-vax, I'm not going to do this. And I said, what if I told you I could vaccinate you against Ebola tomorrow? Would that change what you're doing in the way that you see things? Because there's a very large paranoia out there about this. And I'll wager that a lot of the people who are anti-vax would actually go for that. And so if you get them to rethink the way that they see things, you may be more effective in making an argument than if you try to throw facts or whatever at them. So I would urge you to think about those as you have scenarios in front of you.
That's a really excellent point, is to sort of change the narrative a little bit from, your standard vaccinations, and say, well, we have talked about this in the class that we've had several participants come up so far from, there's a rising whooping cough in Washington and Oregon. Well, you're making a factual argument at that point. I don't know that, again, the person is really committed to this particular view. I don't know that's going to sway someone like Kelsey. Whereas if you change the narrative a little bit and say, this isn't about whooping cough, this is about measles, even though it is, it's, about Ebola, then, that would be really interesting kind of way to frame what's at stake here. So the reason we wanted to focus on this is 2 days ago in the New York Times, there was an article that I read about physicians in one borough, I'm not quite sure, it might have been Manhattan, might have been Brooklyn anyway, that they're doing precisely the kind of our clinic will, because they've had so many kids in New York, it was Manhattan now, so many kids in Manhattan not be vaccinated in the public schools there that the physicians are just saying, no, we're not going to be physicians for families whose kids aren't vaccinated. Just said no. And so this is, here you've got issues of whether you're going to be flexible, accommodating, sort of be responsive to the community, or just take this hard and fast line. And that's, again, it's a real life issue. We're not, it's hypothetical in one respect, but very, very real.
Any thoughts on that?
Me?
No.
Oh,
David. I see you're seeing that.
Yeah, that's.
And it all goes back to that flawed study, right?
Oh, that's true.
Yeah, so.
It's just a complex issue. It comes down to values. And so what you were mentioning about seeing each other's equals. What I like to think about, something that I read, and I forget who wrote this, is that the clinical encounter, the patient-provider encounter is a meeting of two equals. The provider is an expert in the medicine, and the patient's an expert in themselves and in their body. And so if you think of it that way, you'll be very humble in not just telling people what to do, because you realize, oh, there's an expert on the other side. They're an expert in themselves, and they need to teach me about themselves just the way I might need to teach them about the merits of vaccination.
Okay, next one.
Real quick question. So in the first scenario, kind of what you were getting at, where they were addressing the person kind of like telling them what to do almost, compared to the contrast of like patient trying to get to their concerns, like why they're not getting vaccinated. Should they approach the first initial situation, you think, as concerns? Like, why are you doubting this? Like, why are you so concerned about people getting vaccinated or not, and treating them or not, type thing? In like an MMI format, do you think they'd be looking at that more so? Like, are you looking at concerns of even your equals in that sense? Or obviously, I'm not.
I don't have a.
You just have to be a good listener.
Yeah.
You have to start there.
I think communicating and making
Yeah.
a point. I think that's the most important thing, sir. I don't think there's an answer as such.
And then the other thing that you have an opportunity to do here is really dig deep on what the concerns are. And first of all, if they go back to that flawed study, I'm sure every pediatrician has a copy of the information about why that's a flawed study. You know, the one that connects it with Asperger's, right? So, but then, if you can find out what, you know, do you know some people that have had bad experiences with vaccinations, and try to get, you know, a little history on maybe, you know, her uncle, or something or other, some family connection or some specific concern. So the more that you can get specific information, and then you might find that there's a teamwork aspect where there's someone else you could bring into the fold. There's another professional or a family member or someone else that could perhaps weigh in on getting the desired outcome. And the thing that I want to say is that, you know, I go to all these medical meetings, and they talk so much about teamwork and interprofessional education and working together and, you know, learning to ask for advice from colleagues and bringing family members in, bringing the community in, so maybe the whole family would actually be able to weigh in on this. And that's something that they really are encouraging us to have you guys think about, because the whole community is part of the solution, is part of the support system for that patient. And so if you approach things from that perspective when you're doing these, and not that you just know it all, then that will be a good place to start.
So let's try and do this. You're going to be you're going to get rid of it. We're going to show you that kind of stuff. So all you have to do is just moaning. I hope I don't have, or I think I have this. That's all you have to say.
I'm really in pain. You better show me.
You have moaned a little bit.
Oh.
All right.
I'm in pain.
Your pain is where?
Oh, it really hurts.
Can I feel? No, I'm not. And otherwise, you're okay.
I got some real sharp pain right here in the middle.
Okay. We're going to take some tests, take some blood, and we'll get back to you.
Oh.
That's not very good, but that's why I'm not a doctor.
Oh, you better hurry.
Well, we've run these scans, a CAT scan for her. She doesn't have appendicitis. That's a good thing. So when we go back and talk with her, we can tell her that she doesn't have appendicitis. I'm really worried, though, that actually, here's the monitor. I'm really worried that some of this stuff that shows up here looks like there's some masses in her abdomen, and I don't know what those are right now. We really need to do some more testing of that. But I just, now. At least for right now, she's concerned if she has.
You guys talking about me over there?
This is confidential. Just go and just tell her that she doesn't have appendicitis, and we'll need to do some more tests. Okay. And now you're thinking, no, that's right.
No. Do you want me to think out loud?
Yeah,
Or-
yeah,
okay.
you're thinking out loud. Sorry.
All right. So gosh, we know she has not appendicitis. She has a history of some issues previously with some uteral trauma. I don't know if that could or could not be related to these masses that we're seeing now. She certainly doesn't have the appendicitis that she was concerned about. I don't know now if it's better to worry her with these masses, being that we don't have a diagnosis or any sort of necessarily a procedure that we're going to follow in order to diagnose or continue this work, whether or not she wants that, or if I just let her know that she doesn't have the appendicitis and maybe the pain will resolve itself with some time.
Great. So now we need someone to come up here. This is Kelsey's giving you what you're thinking in your head, and now what are you going to tell our howling patient with appendicitis? She's really need some info. Okay, so we need someone to come up here and walk through the rest. What are you going to communicate to her?
There we go.
So you guys were in another room when you were doing that?
Yeah, we were. Yeah.
I just wanted to make sure.
You were actually, this takes place in the ER, so we really should have had Gabe on this one.
They must be patient. You've seen enough of those.
Yes.
Okay.
A confident one.
Okay, so we've gone through your scans, and you do not have appendicitis. I know you were worried about that. So that's something, that's good.
It really hurts though.
Yeah, and I apologize for that and for waiting in the ER. I understand that can be a stressful time, but
I've been here 4 hours.
That's a long time. I'm sorry for the wait, but the scans have come back. You don't have appendicitis, but we would like to look into your scans further to see what really the cause of the pain is for you. Is that something that you'd be interested in? Are you, do you need to get home to your family? Is there something going on now? Or is it possible for us to keep you here so we can go through your scans further and see what really the cause of the pain is?
Can I get something for the pain?
You get something for, well, we're not exactly sure what the problem is, so we're not sure which medication would benefit you the most. So it'll be a little more time before we understand exactly what's going on. But how are you feeling? What do you feel like you want to do right now for treatment-wise? Are you okay with us going through the scans more, figuring out what the problem is? Do you have time for that? Or
So do you want me to stay here to do more tests?
that would be what I would recommend as a physician. Yes, tonight. We would be able to figure out what's going on. Because we know it's not appendicitis, but we're not sure exactly what else is happening.
Does that mean it's pretty serious if I have to do this tonight, or can I wait?
So we're not sure. I cannot tell you either way whether it's serious or not.
But it could be.
It could be, yes. I couldn't tell you it couldn't be because I don't know that for sure. But it could be more serious, but it also could be nothing. So that's why we want to do more tests to make sure everything's okay.
Okay, good. Thank you very much. Sure, you're still there. You've got it now. You've got 4 hours, but you've got 4 more minutes.
All right.
Someone else who wants to comfort our howling patient?
I will.
Go for it. No,
That's you. I figured that to someone else. Okay, so we have looked over your scans, and you do not have appendicitis. So that's the good news. Unfortunately, we aren't sure exactly what's going on yet. So how much pain are you in right now?
Oh, it really hurts.
Like
10.
10, okay. So since we're not sure what's going on, we would like to do further testing to get to the root of the problem. Because
Do I have to do that tonight?
we would like to do it tonight because since we don't know what's going
That
on.
means it's really serious, huh?
We don't know if it's serious.
the further
Am I
testing
gonna
would give us, would give us information. You're
Am I
not going to
gonna
die. If you stay here, we will be able to figure out what's going on and offer the appropriate treatment to prevent further discomfort or dying. So yes, would you be willing to stay further? That's my advice for you, would be to stay and allow us to do further testing to figure out what's going on.
Okay, good. Thank you. So Kelsey's coming, and then David, who is the ER doctor. You've still got 3 more minutes. I don't know why you can't be in that much pain.
Terrible.
And then Gabe, you can. So this is the ER situation. How you might handle this? So.
Well, good evening.
Still really hurts.
Sorry to keep you waiting. I know it can be a bit
5 hours
slow.
now.
Yeah, unfortunately, it's quite a busy evening. We've got quite a few patients who've come in. So we've gone through your CT scans. At this current juncture, I can tell you that you do not have appendicitis. So, that's certainly a plus in my book. However, what we did notice on the CT scans is there are several masses that we're seeing in your abdomen. At this point in time, we are not certain as to what these masses are necessarily, what they represent. It could be something that's relatively benign, something that's not going to really cause you too much problem once we figure them out. However, there's also the possibility that it's something that's slightly more serious. Due to the amount of pain you're currently experiencing, I would have to recommend that you stay here for a few more hours even maybe, so that we can run a few more diagnostic tests in order to actually get a better understanding of what's going on. At this point in time, we really have very little information other than there is something abnormal that we're seeing on your CT scans. I certainly understand that you've been here for a bit. I know it's stressful. I know that it's a very difficult place for you to be, as we don't have a lot of information. But my goal is to really develop an understanding of what's going on so that we can get this issue resolved and relieve your pain on a more permanent level, instead of just treating you with some sort of a painkiller, which will provide temporary relief, but might not actually, and will likely not actually get to the root of the problem.
Sounds serious.
It could be. We don't know at this point, but
Am I going to die?
Unlikely. That's my job, is to keep you here for as long as I can.
Okay.
Dave, do you want to take a role here, or talk with Sherry, or you just observe?
Yeah, I actually think my discussion would have been very, very similar to the very first discussion. I think the only 2 things that I would add, so I guess what I liked about that is, first you sort of acknowledge, or a bunch of people acknowledge the time and the waiting and things like, and the pain, so it's very good to acknowledge the patient's experience there. And then giving the positive, I really, to focus on the positive results. The good news, I'm not seeing any signs of appendicitis. We still have further testing to do. I try not to use words like unfortunately, or however, or but, I try not to take the conversation into anything negative. I just try to keep, so that would be actually the one thing not to change, but would add. I would assess this person, as I'm hearing her role play, as a pretty worried person, but also a worried person who kind of has a lot of questions and maybe has a lot of things running through her mind as to the possibilities. And so I would go back to that confidence thing of the professionalism. I would say we would like to keep you here for some more tests. I feel confident that we can give you an answer as to what's causing your pain, but right now I'm not sure what it is. And then if she persists in saying, am I going to die, what is this could be, I will give the patient the list, a brief list, where I convey to them both the non-serious things, and I throw in some of the serious words so that they can hear them. If this is a patient who's really worrying about all those things, by mentioning the word cancer, you're not introducing it. She's already thinking that. So I would say we're concerned this is appendicitis. It could be some swollen lymph nodes because you might just have a viral infection. It could be a urinary tract infection, some things that we can really fix easily. We're also looking for all the other causes, things like your ovaries being twisted, or mass that sometimes can be tumors. So I throw those things in there, but in a way that's sort of, I guess the overwhelming message is that I'm confident that we're going to diagnose whatever is going on with you. And so yeah, they hear those words, they can think about that during the next hour or so while they're getting the test done, and maybe prepare themselves for some of that bad news that they might be getting. But otherwise, I would do it the same way.
Can I ask you a question?
Let me just say what I felt. When it was more generic, we're not sure what it is, I was okay. When I heard abdominal mass, oh man, I could feel that right here. And so words really do matter on these things.
So is that when you really got scared, or you?
Well, it just, I could just feel it.
Maybe this person is actually has a little bit more knowledge and confidence.
Yeah, maybe so, but just using those words rather than just, we're going to do further tests because we've seen, we don't know what's going on.
Yeah.
Just want you to know that one, I could really feel that when you use those words. And so yes, you are thinking about them all, but it brings it home when you hear those words.
Yeah, maybe not every patient wants to hear that. Maybe to me, it feels a little bit like you're beating around the bush if you start being too vague. So I tend to actually get a little bit specific, but for some patients that actually might
But if you gave a whole range of things,
Right.
then that would be a really good strategy, as opposed to just abdominal mass, because I'm just thinking, oh God.
So I guess my question to you, Gabe, is as an emergency room physician. So at some point you make a decision here that this person really should stay here. And so the ideal world we're talking about is you're mutually making this decision, et cetera, et cetera. But in your mind, you've decided this person really shouldn't be out. So that there's a this firmness or some, that, well, I'm sorry, but we really can't do this. And I think that's a difficult thing for students to learn to balance. Where do I have well, we want everybody to, play together and make this mutual decision, and other places where you have to say, I'm sorry, but we have to do that. And so can you give any guidance in terms of how you play that role in the emergency room?
Question. The first thing I do, and sometimes it's not possible, is I try to look for an avenue where they'll then join me and want to stay, I guess. So in this instance, it's the pain. This instance, you have the patient, I think, because they're in so much pain that I think by telling them, I can help you feel more comfortable while you're here, but we also need more time to do some more tests, or just use the word but I don't usually do that. So finding something that I can offer them that will bring them on the journey with me, I guess, so to speak. That's not always possible. So then if that's not possible, I think it's just being both, like you said, just confident, showing them that you're considering all the possibilities, and then I guess the other thing is concern for them. So I think it's different to say, you need to stay here and get a bunch of tests done, or I'm really concerned about your pain, and I would feel uncomfortable if you were to leave in this much pain. Okay. You're saying the exact same thing, but it's totally different, and I think we heard totally different by the patient. So I guess the take-home message, which I got around to in roundabout ways, showing concern for the patient.
Okay. Jason, you can show your hand up.
Sorry, address.
Sure. Yeah.
Well, I was just going to say that with that second method, it's kind of more like, we're going through this together. Where the first method, it's like, listen, we got to get these tests done, and you kind of feel on your own. You're like, wow, I have to go through these tests. With that second method, you're showing, listen, we're going through this together, we're going to figure this out. So I think that approach is definitely the best way. It's like a good balance between being, direct, but showing, listen, we're gonna get through this together. So I think that's another good reason as well.
Yeah, it may not be possible to go back to Pam's point that the decision making may not be shared in here, but you can share something else, and that's what you want to focus on. I think that sharing of something is really, really critical. Alan?
So in an interview situation, would they say, like, you're going to be a doctor, go talk to this patient? Because I would feel so uncomfortable, like, speculating about, oh, you're talking to a patient about abdominal pain. Well, let me throw out some things from my mediocre knowledge of medicine.
They're not going to expect you to be a medical doctor.
Okay.
So you're playing a role, okay? So you're not going to say, okay, well, this is appendicitis because you've had X, Y, Z. I mean, that's not what the purpose of the interview is, right?
It's about the conversation.
So would it be more like a comfort this patient while they're waiting in the ER or something?
Well, no, it's deal with the situation.
Okay.
That's what this was about. This was dealing with the situation. That may involve some comfort, that may involve some listening, may involve some talking, may involve some decision making, but it's playing that role. That's what these types of scenarios are all about.
Okay.
Okay? So I always tell students to remember that an interview is not a fill-in-the-blank exam. Okay? There's an answer. There's a right answer. There's no like, this is what, if I don't get this answer, I'm going to have, it's not going to work. I don't know how to diagnose abdominal pain, right? That's not about that.
Okay.
So just remember that as you're going through.
Okay, so if I had gone up there, it would have been okay to skirt around any type of, like, oh, we're going to run a CAT scan, like, oh, I don't know about that, so we're going to try and...
They're not going to expect that you're going to be an expert.
Okay.
No, you can say all kinds of things.
Okay, so I can kind of skirt around that, not worry about it.
Yeah. Yeah. Okay.
I think it's just really important to be open and honest and communicate effectively with your patient. You're going to have, cultural differences, cognitive gaps between your clinical intellect versus the patients you're going to be dealing with, and find some sort of effective modality of communication. Personally, I would much rather prefer very, very harsh news. I would much rather be hit hard with the possibility of abdominal masses than have ambiguity. Because personally, that is more fear-inducing, personally. If you have a patient that maybe is not compliant with or in line, if you will, with your recommendations, maybe showing CT scanning. I don't know. Some people don't do that, some people do with almost every patient, but that way you have some sort of platform for effective communication, let them understand the severity, at least understand where you're coming from. Maybe they could be in denial as far as the severity of the situation, maybe something to really hit it home in a constructive, but precise manner. So
I think in an interview situation, it's good to acknowledge the duality of that. People will be different, so their approaches will be different. But then there's some things that are really should be common, which is expressing that you're taking that journey with the patient, or bringing the patient along, showing the concern for the patient, trying to elicit the patient's story. Those should be universal. Whereas what you're saying is exactly right. You show in the interview that you can appreciate both sides of issues that do have two sides.
Okay. We probably have time for one more.
We do. Okay. Well, yeah. Let's see. How are we going to set this one up? Yeah, I should be the physician. We'll just do that. So how'd my test look today?
It looks like everything is going well. You seem to be continuing remission. There's nothing that I am terribly concerned about at this point. Nothing I'm concerned about at all, actually. It looks like you're recovering as well as we can hope for. So at this point, we're going to continue, with visits every 3 months just to make sure that you're continuing along this path. But other than that, I would say you're doing very well.
Great. Well, I'll look forward to seeing you in 3 months. Can I ask you something before I go?
Certainly.
There's a elderly woman that I live close to, and I do a lot of things for her. She's in kind of a bad way in her household affairs. And she's been taking, I help her out with her household. I run some errands for her. She says she's in a lot of pain, so she's been taking Percocet to alleviate some of her symptoms. And she's one of these people that, she's really a wonderful woman, but she just, physicians are not for her. You probably understand that. She doesn't want to come into the office. I've offered to bring her to see you, but she just says no to doctors and to the ER and anything that's medical. The problem is that she's run out of her supply of Percocet. She maybe has 1 or 2 more days left. We've even tried it, and sometimes I've given her some of my Percocet. I bought her some off the street for about $5 a pill. And I just wondered if you could help her out and help us out here, because I'm really concerned with her and care for her. And would you be willing to write a prescription for Percocet for her? You know, I appreciate all you've done for me, but now I'm trying to be a good friend to my friend, and wondered if you could help us out with Percocet for her. Yeah. Okay. We need someone to respond, be a doctor. Want to go again?
Sure.
Okay. Do you want to do this one now? You're really good as a patient. Well, I mean, you could be a doctor. She's now the patient. Just
Got it, yes. All right, so I think it's great you're helping your neighbor out, and I'm sorry she's gone on some hard times, but unfortunately, I cannot prescribe medication to someone that is not my patient directly, and I know it's hard to get her in here, but there's no way she can get this Percocet unless a physician sees her and prescribes that to her. So I would feel uncomfortable, and it wouldn't be okay for me to prescribe medication if it is not for you.
Okay, so what I was kind of hoping is that you might be willing to write me a prescription for Percocet.
Right, I understand, and
I can fill it and pass it on.
Right, but at this time, I don't feel that you need Percocet, and I would, for all my prescriptions, it needs to be, I need to know that you are needing the medication. It cannot be for someone else, and that's just legally not allowed. So I can, if you need me to schedule an appointment with her, if she can call, that's the only way I can really get that medication to her. I'm not allowed to prescribe you the medication because I know you, at this time, are not needing it.
Doctor, says the resident, how about we go visit this woman at her house? Can we do that? Maybe she might not come to us, but we could go to her and perhaps see, diagnose her and do an exam. Maybe we could help her out.
Yes, yeah. Good luck. That's the end of your residency.
What?
That's the end of your residency.
So if the patient is unable to come into the clinic, I would not feel comfortable going to her house if she's not the one calling to see if she can get an appointment. If she doesn't like physicians in the first place, she would really have to come into our facility. It wouldn't be okay for us to go to her.
Can I go visit her? This all was a conversation. I am role playing that. This was a conversation that went on this one.
I don't think that is necessarily appropriate for us to do. I think the patient really needs to, well, not even a patient yet. I think this woman really needs to, on her own initiative, call us and schedule an appointment if that's something she would like to do, or if she wants this purpose.
I mean, as her neighbor and her friend, my concern is that she's getting to a point where she is in quite a bit of pain every day. Like I've mentioned, she already took to actually trying to buy the drug illegally. Where I'm getting concerned is that being a 7-year-old woman and buying illegal drugs, she's going to get mixed up in something she really can't handle, and things are going to spiral worse out of control from there. If there was a way that I could get her to consent to coming in, I would have done it. But this is really, I know I put you in a tough spot by asking for this. This is really my last recourse.
And I appreciate your concern, but I really think the only way is telling her all of your concerns. I don't know if you've done this already, but just full disclosure to her, letting her know what the situation is, letting her know the concerns, and hopefully you can spark something in her that lets her know that this is something she needs to do, and she needs to turn it around, get this medication if it's really necessary for her.
I don't know if it's necessary to do.
Are there any other things that you could say to this patient?
I guess if I was in that chair, I wouldn't be saying something like, because I would also say no to writing the prescription, but I'd say that you have, since you do have a personal connection with this neighbor, that you have a wonderful story about the successes of medicine because you're in remission from cancer and you survived a great disease. that you might be able to share this story with your neighbor and potentially be able to convince her to come see me or another doctor who's helped you through your process. Because if you're able to make that kind of connection with her, she might be able to trust a doctor to help her.
In this situation, I also provide some additional resources. I'd say that there's clinics available. I know that the interview probably would take place in Corvallis, but something along the lines of community outreach.
Right.
You know, there's other resources
Social
available and social services available aside from either getting or prescribing the prescription to you and then you giving it to her or her coming in directly. There's other avenues such as that you can explore in order to help help that lady.
And that's the teamwork thing, because you look beyond your immediate circle to see what other resources might be available. It's good, yeah.
So maybe just a little different perspective, I suppose, but I'm from a pretty small town, and and I work on the ambulance there, and then sometimes I'll have a patient, we'll take them down, and the week after I'll swing by their house and say hi, see how they're doing. So is there anything particularly wrong with doing a house call, if it's besides the practical implications of it? But I mean, I don't know, I would feel fine if it's, I knew this is a small community, swinging by and saying hi, and maybe just taking the time to chat. I don't know.
Let me weigh in on that just because I really like your answer about the fact that the person had made no effort to contact you. So you didn't really have a patient. In your case, you've treated them, you've had a relationship with them, and you drop by to see how you're doing. It's a very different thing than somebody who's made no effort whatsoever to come in, okay? And now you're going to go out and say, okay, here I am, right? And there's already reasons why you might not want to go there. So I really like your answer to Kelsey's situation.
Yeah, and this particular case did take place in an urban setting, which would be a little bit different. Maybe the physician was, well, actually the physician first turned to the resident and said, "What do you think we should do?" And the resident kind of mulled it over and then said, "No, you can't write the prescription for the patient." It was a male. But then afterwards, but he did raise the possibility later on of going to see, making a house visit, and the physician said, absolutely not. I mean, that's not a patient, no responsibility. This patient doesn't want to see doctors for whatever reason. Not going to help us by showing up, or not going to help her by showing up on our doorstep. But so that was kind of the end of the conversation. And the evening later, the resident just feels that they had not fulfilled, according to his values, what it meant to be a healer. It's a very powerful story. If you want to look at this, it's in a book called The Soul of a Doctor. Harvard physicians write about their experiences in medical school or something like that. Anyway, it's really kind of very striking story. So.
Thoughts on that one, Jane?
Well, there are cities that do home visit programs. San Francisco definitely does home visits through UCSF, so it's not an unheard of thing. So I thought that was actually a really interesting idea. And I also agree with Dr. Ahern that it's a very good response to say, well, there's an issue here because I don't even know the patient, they need to get in touch with me. So I might have been a little less hard line about it, though. I think this case has definites and ambiguities. And the definites are, yeah, of course you can't prescribe a Percocet, we all know that. But then there are a whole bunch of questions. Going back to what Dr. Ahern said at the very beginning, when you first hear the case, you're going to have the instinct to ask the question, why doesn't that person, is there a barrier to that person seeing their own doctor, or do they have a doctor, or do they just run out of their Percocet? There's a bunch of questions there, and those are the questions that in an interview setting that I would verbalize out loud. And if I had a role play, then I would even ask the patient. I would say, well, what are the issues around your friend not being able to see a doctor or get her medicine, or is it a transport thing? Maybe just try to figure out some of the issues, and then you might be able to sort of go to some of the solutions. And half the solution is you have to say no to Percocet, obviously. But there might be something you can work with, like a home visit, or some sort of community outreach.
The social worker might be less intimidating than a physician to get started on the road down to getting what she needs.
Question here.
Should the doctor have said something about the fact that the patient was sharing medication with a neighbor?
Another crime involved.
Right on the street.
I like the fact how the first physician actually validated the patient's concern. That was very sweet. Yeah, and I usually say something about that, not in a jerky or you shouldn't be doing that, but saying, hopefully you built up a rapport, you can kind of smile with the patient and say, the best thing would be giving your Percocet to them. A lot of people can overdose on Percocet. Let's come up with a better solution together. Let's figure out a way that we can do this maybe in a safer way for your friend.
That's a gray area there. A lot of those. And those are all real cases.
Yep.
Thanks.
Yeah.
I'm sorry?
I'm going to have to run.
Yeah, that's fine. Yeah, you can go and I'll any last questions anybody wants to throw out? I know some of you have already been out on interviews. You were. And a bunch of you I know haven't scheduled. A lot of you are going to be heading that way next year. So, any questions?
Can I put in a plug? So I teach a class in the Honors College on interview skills, and I hope that you'll check it out. You don't have to be in the Honors College to sign up for it, but you will have, if you're not in the Honors College, you will have to petition at the Honors College desk now in Wendiger Hall on the second floor. I've also got a free book on how to get into medical school that encompasses a lot of MMI interview situations, there. It's free download, so if you'll send me an email, I'll be happy to send you a link to it. My email address is, I can type it in your right, Ahern K@onit. And send me an email, I'll be happy to send it to you.
What's the class that you teach?
It's called BB407H, and it's called Science and Public Eye.
It's a great class. You can take it, do it.
I paid her.
I've been doing a lot of mock interviews with students.
Good luck, everybody. Thank you.
Thank you.